This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hello, I'm Dr. Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon in New York City and New Jersey.
I'm Marina Kurian. I'm a general surgeon and a minimally invasive surgeon here in New York City.
So we are wrapping up 2020 with our final live show of the year today, talking about COVID-19, about epidemiology, about emergency medicine. Our guest today will be epidemiologist Dr. Teresa Chappell, PhD, and emergency room physician Dr. Lauren Shawn. We're going to be discussing lots of important issues, including maternal and child health, when to go to the ER. We're going to talk about opioids, parenting during COVID, a bunch of stuff. We have two really smart physicians and scientists on the show today. So please like and share and tag your friends who might be interested in participating in the conversation.
Yeah, absolutely. So this is going to be a great show. We're excited to talk to our guests. But you guys know that Suju and I are going to do a little bit of the rundown of what's been going on with COVID. And this is our last 10-minute chit chat about that this year. So, you know, the U.S. has, we didn't think we'd get here, but we're here. And we've passed over 300,000 people that died of this disease in the United States. And unfortunately, we're looking at between 2,500 and 3,000 deaths a day. And that is essentially 2 people every minute. And that's a lot. And so this is just showing you where the hot spots are. The darker colors are worse when you're looking at this particular map. And, you know, worldwide, 1.65 million people have died, and over 70 or close to 75 million people have contracted it. And Suju, we were just talking about in our pre-show, Suju and I were just talking about how my friends in London are on, they call it tier 4. Of course, it's much nicer than the levels. We have what? Orange, yellow, red. They're like tier 4. So they're on tier 4 lockdown in London and southern parts of the country because they have a new variant of COVID-19, which is more infectious, but maybe not more lethal.
Right. So it's easier to transmit, but it doesn't seem to be causing more hospitalizations or deaths, thankfully. When you listen to the infectious disease and vaccine specialists, because the vaccines are against the spike protein, against only part of the viral coat, the idea is we've seen some different variations of this virus already in the past 9 months to a year, but they believe that the vaccines would continue to be effective. We're not sure. So this is unfortunately a developing story, but it has led not only London to go into tier 4, but many European countries to go back into lockdown. Many parts of the United States have shut schools and restaurants and bars and events. So this is, despite the development and the approval of the vaccines, this is still an ongoing public health crisis.
And maybe a lot of you guys, if you've been checking your Facebook feed or whatever, you've seen a lot of, and Twitter, a lot of our colleagues who've received the vaccines have tweeted about it. And it's not, as one of the Twitterati said, it's not because we're showing off. It's because we want you guys all to get it. So we're happy to show that we took it. We didn't grow an extra head. I haven't gotten it yet. I'm waiting. And Suju, this is a couple of our prior guests on our show, Dr. Quinn Capers, and he, you know, very beautifully is shown here getting his vaccine. Is no tears
No tears. And Monica Verduzco Gutierrez, who's the chair of physical medicine and rehab in San Antonio, is getting her shot. You're seeing a number of healthcare workers from across the country getting their shot and thanking science. And then, of course, I had to put in a picture of Gandalf from Lord of the Rings, or Magneto from X-Men, Sir Ian McKellen, who got his vaccine a couple of days ago as well. The first person who got the vaccine in the United States outside of trials was an intensive care unit nurse in Queens, Sandra Lindsay, who got the vaccine from Dr. Michelle Chester. And you may notice that the sort of the PR shots are highlighting people of color getting the vaccine. And that's something I really want to talk about with our guests, Dr. Chappell and Dr. Sean, when we get to them. But there's some really kind of cool stuff out there, Marina, and you made sure I remembered to think about beauty and music this week.
Yes, indeed. So, we always talk about COVID. We're going to come back to COVID, but this week, Carnegie Hall Live honored some of our colleagues who are also excellent or exquisite musicians. And I was watching the show and I was like, the two people on the left are actually Dr. Chandrasekhar's colleagues. And they're like, yes, we work for ENT and Allergy Associates, and or work with, or what, they're probably your partners. And I was like, yeah. And I'm like trying to grab screenshots and send it to her because I was like, wow, that is so great. Meanwhile, I was watching the show with one of my colleagues who is also on there. So your colleagues, mine is Dr. Tony Vine and Dr. David Edelson. And
mine are Dr. Melin Geller and Dr. Neil Proofer. And so you saw them playing piano together. You see Tony and David playing the violin. The person in the sort of pink magenta shirt is the violin virtuoso Joshua Bell. And one of the pictures shows Neil Proofer actually accompanying him on piano. And then we wanted to highlight Dr. Esther Chu.
Yeah, so I am pretty sure she plays something, but she opted not to, play for this show. But she gave a beautiful message. And I think all the doctors got on and gave the same message, which was stay tuned for the vaccine. But in the interim, even if you get that first shot, you should still be, where's our mask slide? It's happening. Wear a mask. Practice.
Wear your mask, right?
Wash your hands. Don't touch your nose. It's hard, I went to walk the dogs and, I have to clean up after them. Mm-hmm. Trying to get in the cold, trying to get those bags apart. And now with a mask on, it's not like you can spit on your fingers or do anything, right? You have to kind of try and get it apart. I'm just telling you, those are real world struggles.
They really are. Even if you get the vaccine. So the vaccine, as we talked about last week, the vaccines at the moment that are approved are Pfizer and Moderna. And this graphic reminds you that even if you get the vaccine, the pandemic is not over. So wear a mask, watch your distance, wash your hands. Those are the 3 W's. The vaccines require 2 injections each to be effective. Not one. Some of the governors have been saying, just get one. No. They're approved as 2 injections, an initial and a booster. So the Pfizer one is 3 weeks apart. The Moderna one is 4 weeks apart. And there's a rollout plan. So there are 17 million healthcare workers in the United States. There have been less than 300,000 vaccines given so far this week. So this is going to take a while. And I think there was a really interesting article written by a physician talking about how different communities may have more difficulty accessing the vaccine. And it's also something we need to talk about. But no matter what, so this is an article by Rebecca Fenton, who is at Northwestern University, a physician, and she says why the coronavirus vaccine may not be accessible for those who need it most. And, there's a whole secondary social science that comes into whether people will be patient enough. Neither Marina nor I have had the vaccine yet. And oh my God, are we dying for that email. I mean, how many times do you keep refreshing your email to say, can I get the vaccine yet?
Yeah, and our hospitals are trying, and there are a lot of people that have gotten it. The worst thing I think that happened is at Stanford, only 7 of the residents got it in the first tier, and that was an outrage. And they are also trying to rectify that because the residents are actually the first line to go in.
Absolutely.
With our docs.
Yeah, they're in the hospital all the time. They're doing the COVID tracheotomies, let's say. They're being exposed to aerosolized materials. And I was really proud of the resident staff for, in fact, striking and saying, no, you have to care about us. And I was very proud of the faculty for realizing the mistake, screeching to a halt, and rejiggering the algorithm so that the people truly at the front lines will get the first set of vaccines.
Actually, at Stanford, Mary Hahn is a surgeon. She told all of her faculty that got emails for the vaccine to instead get one of the residents and take the resident down and give them their time slot. And I thought that was like excellent leadership. We're going to get to our guests now. We're so excited to have Dr. Teresa Chappell join us. And again, she's an epidemiologist. We're going to be talking about COVID-19 as well as a lot of maternal health care issues as well. And Dr. Lauren Shawn, she is ER physician. And we're going to talk to her about what's happening in the ERs and what we can expect and when we should actually go to the ER. So many questions for them both.
So we have people watching from all over. So welcome, Teresa and Lauren. Thank you all. Thank you both for coming on, and thank you to our viewers for tuning in. Please remember to like and share and tell your friends. And Monday from 2 to 3, we are on WBAI, which is 99.5 FM in New York, and WBAI.org around the world. So you can find us there as well. So welcome, Teresa and Lauren.
Hi, thanks for having us.
Hi, good to see you.
So let's talk a little bit actually about what you guys do instead of, we're going to break up our COVID talk and then we're going to go back to it. It's like the COVID sandwich. Start with COVID, non-COVID, back to COVID. Okay, but first.
It might be a triple decker.
Teresa, a club sandwich? Teresa, can you talk to us a little bit about how you got into epidemiology, what you do? One of your colleagues in Sweden, Dr. Anders Tegnell, right? So he's probably one of the other well-known epidemiologists, but you are Twitterati. We love having you on, and you have quite the following, but it's because I think of the messaging. And if you can just describe your background, how you got here, I think our viewers would be very interested.
Sure. So I am a maternal and child health epidemiologist. And my background is that I hold 2 PhDs, one in maternal and child health and one in epidemiology. And what I do is try to prevent any adverse outcomes that can come to anyone during pregnancy up into 1 year postpartum. And that's with both their pregnancy and the baby and the delivery. So a lot of my work is really focused around what are those negative outcomes that can happen? How can we prevent them? And it's led me across the spectrum to chronic diseases, to infectious diseases, and on and on. So I have done a lot of, I've worked a lot of epidemics and tried to decrease the impact of those. Things like Shigella outbreaks in daycares or measles outbreaks in daycares. So I really have worked that spectrum as well as trying to prevent things like infant mortality and fetal death and maternal death. So epidemiologists, we tend to look for patterns and distribution of diseases. We want to know who gets it, why do they get it, how can we prevent it, and then try to put in place those mechanisms to prevent disease or even negative outcomes of those diseases from happening. So that's pretty much what I do.
Oh, that's it? That's so much.
But that's not all you do, because then you have to take that very knowledgeable information, that data-rich information, and give it to us poor doctors who then have to do the right thing, right? The poor medical doctors. So we really appreciate what you do, because I think our understanding of not just outbreaks like this, but as you said, normal things that happen to people. Women have babies, right? How do we make that process safer and better? We did mention earlier about the op-ed by Rebecca Fenton about communities lacking access to COVID vaccine. So as the first part of our club sandwich today, can you tell us a little bit about what you think is the barrier to proper community-wide vaccination?
So I do a lot of science communication around COVID and around the vaccine, especially trying to target the African American community, because there is a lot of mistrust in the medical community, and the African American community and Latino communities are right to be mistrustful of the medical community. There have been so many injustices and mistreatment for people of color as we interact with the medical community. So it makes sense that the first thing we would think is, no, we're going to stay away from this. We're going to watch and see what happens to other people. We're not going to just jump head first into this. And there needs to be some work done to rebuild that trust. And the rebuilding of the trust needs to come from the science and medical community. It does not need to be another thing that African American communities have to do, but it has to be something that the medical community is constantly coming out and saying, we know what we've done wrong in the past, and these are the ways that we've tried to rectify it, and these are the reasons why we're going to continue to work on your behalf. So in that, earlier in the piece this morning, you guys talked about the first nurse to be vaccinated in the U.S. outside of a trial, and how she was being vaccinated by another Black female doctor. And that was an amazing sight to see. And I actually watched the clip with my daughters. It was about a 3-minute clip that they played on MSNBC. And I watched it with my daughters about 5 times. Because one thing I want my daughters to know is that, yes, mistreatment has happened, but we now have people in leadership who look like us, people in leadership who are fighting for us, and trying to make the medical world better and safer for us. And I want my children to see that so that they're aware that there are things that can change and rectify some of the injustices that were done to us in the past.
I think that's really important. I read somewhere that we need to make sure that our institutions are truthfully more believable and more honest, rather than putting the burden on people who have been marginalized in the past. It's funny that you say that about representation, because in our little friends group, my friend Susan's children, the only doctor they knew for a long time in the neighborhood was me. So when they found out that one of our male friends was a doctor, they were like, "Oh, boys can be doctors too? That's weird." So I think representation does matter in a very interesting way. Lauren, maybe we can talk to you as an emergency room physician, leaving COVID aside again. Why do people go to the ER? What are the top 10 for men and women? Because I think it's different as adults. And then when should people decide to go to the ER, and when should they decide to go to urgent care centers?
Wait, hang on. I want to know how Lauren decided to become an ER doc. Come on. Yeah.
So,
you had that surgery ER battle, right, Lauren, in residence?
Right, exactly. I mean,
you're younger than me, but then we were like friends.
It's, I think sometimes emergency medicine is sort of treated as sort of the mischievous stepchild of medicine, because people just sort of assume we're not actually specialists in anything, and what we are specialists in is in emergency care. And so the way that we kind of approach patient evaluations is a little bit different than other fields, because what we're trained to really do is look at a patient and try to figure out, even within the first few minutes, are they imminently in danger? Is there something life-threatening or limb-threatening? Or when you talk about the things that people commonly come in for, like belly pain, chest pain, headaches, back pains, are they actually presenting with something that really needs emergency treatment? It's a life-threatening condition, or is it something a little bit more mundane, like, it's, some indigestion or heartburn or just a regular, sinus infection or something like that. So that's sort of the way that we approach things. So sometimes, so getting back to me just briefly, the way that I got interested in emergency medicine is I don't really come from a family of doctors. I was a neuroscience major in college, and I assumed that I would end up being a neurologist. And then when I got to medical school and actually started seeing patients, I kind of fell in love with emergency medicine. I liked being decisive. I liked knowing how to handle a lot of different issues. In a given day, I could be suturing a laceration. I could be resetting a joint. I could be diagnosing a heart attack or, diagnosing a stroke. And so there's just lots of really interesting things that I get to deal with, and I get to meet patients from, and I used to work in New York City, like all over the world and all different backgrounds, and it's just been a very interesting and fulfilling field to go into. I think COVID has sort of changed things a little bit in terms of people being afraid to seek emergency care, unfortunately. We've had issues of patients having more complications because they were afraid to go to the emergency department because they were afraid they were going to catch COVID, or they were just hearing how full the hospitals were. So, what I'd say is right now, if you are concerned about a medical condition, obviously you can call your doctor. Usually when we talk about whether you should go to an urgent care or an emergency room, I think some patients have a good sense of that. So the minor kind of cough, cold, you maybe sprained your ankle, you might have a simple laceration on your finger, things like that are perfectly fine for urgent cares. If it's something like, you're having pain in your chest or really bad pain in your belly or, really having trouble breathing, that's something that maybe is better seen in an emergency department, just because sometimes we have more access to invasive testing, imaging, and also you might actually have to stay in the hospital to complete your care. So, that's sort of the way that we kind of break it down. I think right now, it's funny, I have a lot of friends who've gotten some cuts and scrapes and will FaceTime me or text me pictures being like, do I need to get this, sewn up? I'm afraid to go to urgent care because it's all COVID right now. Everyone's just going there to get COVID tested, which is sort of true. I mean, urgent cares are doing the brunt of a lot of the community COVID testing right now. So I think that's also become a little bit of a complicating factor for patients deciding, should I go to an urgent care or an ER? Is there sort of fear about being around, COVID? But I would say that if you have a medical issue that needs urgent attention, then still come in. We have plenty of safety precautions in place where I work. Unfortunately, sometimes that means no visitors. No one can actually sit with you in ER, which is unfortunate, but we're trying to decrease transmission. We have mandatory masking policies. I know some urgent cares are setting up actual appointments to sort of decrease the number of people physically in the space. So we're doing our best to keep our patients safe. So if you have a concern that something is wrong, please still come in and get treated and seen.
One of the numbers, Lauren, that they said that is that 1 in 5 adults will go to the ER each year. But then that's translating to a total of 150 million ER visits. I still feel like it's a lot, but it's not a lot. It just doesn't, 150 million is a lot. I know. It just seems like there's 330 million of us, right, in this country, not counting the people who come to visit that go to the ER, our travelers. It's still a lot of people that a lot of throughput through
right.
Emergency room and urgent cares.
Right. And so that comes into play. I mean, I think it's a little bit of a multifactorial issue from more of like a public health and medical infrastructure issue. So, one of the reasons why people seek emergency care is they generally are concerned they have an emergency. But beyond that, for some people who come in, especially when they come in, things have been bothering them for a few months, it's clearly not life-threatening, it's more just distressing or annoying. They might not have access to primary care, or they might have a doctor, but they can't take off time from work. And they literally are coming in at 9 o'clock at night or coming in on the weekends, and we're 24/7, 365. So sometimes there's an issue of access. And so, I know there's a lot of debate and discussion about how best do you solve that in terms of creating better access or more appropriate access for patients, because emergency care is expensive care. I'm sure anyone who's gotten an ER bill sees how expensive it is. And some of that comes from the fact that we have to be fully staffed and fully stocked with supplies 24/7, 365. So there's a massive overhead. Again, it's a whole conversation about the healthcare system in general and what things cost. And I'm not necessarily advocating that things should be expensive, but I think sometimes people have this idea that emergency care is efficient. It's not. It's expensive. We are able to do certain testing like blood work and certain types of imaging probably more quickly than if you'd gone to your doctor and just got an appointment to go to a radiology office or to go to an outpatient lab, but you're going to be with us for hours.
Right.
Getting that work done. And it's expensive work. And I'm not saying that to defer people from going, but to sort of understand our limitations. You know, I've had some patients come in and they've had chronic back pain and they're really frustrated and really uncomfortable. And they're like, well, can I get an MRI? And I'm like, I can't actually do that in the ER. Like, that's not something I have access to. So, you know, sometimes we're good at figuring out the life-threatening stuff. We're good to make sure that you are safe to continue on with an outpatient workup. However, getting people access to proper outpatient follow-up, proper outpatient care, and just general good primary care access is a much larger issue that sometimes we are sort of the catch-all for everyone. You know, we are a little bit of the social safety net, and a lot of what we deal with is actually sort of the acute crisis of a lot of these bigger public health issues.
You guys who are watching, if you are enjoying our conversation, please do share either on YouTube, Facebook, Twitter, LinkedIn, this show. And because we have great guests, we have Dr. Teresa Chappell and also Dr. Lauren Sean, and we're talking about the ER. We've had some great questions from our audiences. So Suju, you want to start with the first one?
Sure. So Dr. Nina Yashvi in California, who is an early bird apparently, asks, is the vaccine recommended for pregnant women if one has already had the virus? And I wonder, I was actually listening to Lippy Roy on Sri Srinivasan's New York Times read-along this morning, and she had an answer for that. But I wonder, Lauren or Teresa, if you'd like to weigh in.
I'll start with the end of it. So people who have already had the virus are recommended to get the vaccine. Now, for pregnant people, the ACOG, the Association of Colleges of Obstetricians and Gynecologists, their membership organization just put out a position paper saying that they believe that pregnant and lactating women should have access to the vaccine. Right now, there's been no pregnant or lactating women included in the trial on purpose. There have been a few women who've gotten pregnant while participating in the trial, but data has not really come out and looked clearly at the impact of the vaccine on pregnant and lactating women. So while ACOG is suggesting that those women should get it, right now there's not a recommendation.
Right, that's the issue, right? Because the studies were done looking at more mainstream categories and not high risk. I mean, so they didn't do a lot of the studies currently are looking at elderly, but they didn't in the first go around look at elderly patients or young patients, and certainly pregnant women were left off that list as well.
So I think Ellen Austin had a question about the elderly. So her question is, was Moderna tested more in people over 70 rather than the Pfizer vaccine? I actually don't know if it was. I know that it's being rolled out in nursing homes where people are obviously, the patients are well over 70.
I think Moderna did actually include older patients. It wasn't the majority of their study, right? But they did actually do that. And, that's the extent of my knowledge. I don't know if the reason they did that was because they saw how the other studies were going and that group was excluded, and yet that group needed to be included, so that they added like an arm. But I'm not sure that it's a better vaccine for the elderly. They just were prescient enough to include that group in their study.
And actually, in the Moderna trial, there was a pause because there weren't enough people of color as well included, and that arm expanded. So, as the sort of the vaccine race happened, I think they were very thoughtful about including groups that are normally not included, and making it more universally applicable. So, Teresa, I wonder if we can switch gears a little, because your expertise is really you have many, many expertises, but your passion before COVID, at least, was maternal and child health. And we know that there is a huge racial disparity in the United States related to childbirth issues for the children as well as for the mothers. We know that women of color have more preterm babies and more low birth weight babies. And I wonder if you can talk to us about why that is, and then what the point, like, why is that important?
Great questions. So yes, in the United States, Black women are about 2 to 3 times more likely to have a preterm baby, 2 to 3 times more likely to have an infant death, 2 to 3 times more likely to die as a result of pregnancy. And when we think about why these things are happening, it really is a result of not race, but the way that race is kind of played out here in the United States. So the way that Black people are treated as a result of our race and not our race particularly. Because when we look at it biologically, there's almost no racial biological differences between a Black person and a white person. But yet when we look at our health outcomes, our health outcomes are worse when it comes to these maternal child health conditions that we're talking about than white people. And even when we think about those things that are seen as risk factors or protective factors for one race is not seen as protective factors for another. So things like marriage, marital status is a protective factor for white women. Education is a protective factor for white women. The higher they go in education, the less likely they are to have any of these adverse birth outcomes. But for Black people, a Black woman with a college degree is more likely to have a baby die within the first year of life than a white woman with out of high school education. So even when we quote unquote do everything right, Black women are still experiencing a higher rate of our babies dying, a higher rate of the mothers dying as a result of these things that should be really joyful experiences. So it really has to do with things like there's a weathering hypothesis that says that for Black people in the United States, kind of the older we get, the more kind of stressors that are now weighing on our bodies, and it then kind of changes our trajectory through life. So the age, a 25-year-old Black woman has more of the health conditions that are related closer to a 35-year-old white woman because of the weight and oppressions and things that are coming to us as a result of racism. And so I think that that's one of the things that we think about when we're looking at these birth outcomes, because they're so tied to age. But what happens if your body is aging faster as a result of outside stressors? So that's one of the reasons. The others are, we look at things like, nutrition, health outcomes, all those types of things. But even when a woman has done and healthy, she's been healthy leading up to her pregnancy, she's at a good weight, she doesn't have those pre-existing conditions, we still see that Black women are having preterm birth, infant death, and maternal mortality at a higher rate. And for example, I'll use myself. At 34, I had my first preterm baby. I was a doctor at the time. I had 2 PhDs. My husband was highly educated, and we were high income. All the things that would be protective factors for white people did not work in our favor. And we still had both a preterm baby and a small for gestational age baby, which is low birth weight as well. And so it's really, I think what's really been the underlying cause for what's happening with birth outcomes for Black people really has to do with the treatment of Black people in America.
And there are some really long-term effects of very low birth weight, right? So that when children are born on either end of the spectrum, very high and very low, but very low is unfortunately, as you said, common despite everything, more common in women of color and in Black women in particular, more than anything. So can you just talk to us a bit about those long-term effects? Because I think that ends up being children who end up in the emergency room more often. So maybe we'll start with Teresa and we'll go on to Lauren.
Wait.
Except for Marina has something to say.
Teresa, it's just shocking to me, right? What you just said was incredibly painful and horribly shocking to me. That should happen here and happen to someone educated and doing all the right things, quote unquote, right things. How can we compare that to other countries where there is, like, let's say, does this happen in predominantly Black countries? How does it correlate to what's happening in this country? Do you have that data?
I can talk a little about it. My expertise is mainly what's happening with minority populations here in the United States, but there's been some work with, it's called the Hispanic paradox. So when Hispanic people from Spanish-speaking countries, they have really great birth outcomes in their country. And then after they come here for a generation or two, so it's not the first generation, it's the next, they start to have birth outcomes that are more related to birth outcomes of the minority population than the really great birth outcomes they were having in their country. And we see that as well with people coming from African countries coming over here. The first generation does well. Maybe it's about keeping their customs and things, but the more that they assimilate to the United States, the more their birth outcomes start to look like Black people in the country. And it can also be that, when you come to this country, you initially stay within your smaller group, and that way you get to keep your customs, and you also have protection from outside forces like racism if you're staying within your close-knit community. But the more that we see people assimilate and start to become more Americanized, then we see that their birth outcomes look more like minority populations.
So, you were talking about the fact we have this graphic on long-term effects of extremely low birth weight, and really show significant problems with IQ and learning and motor skills and behavioral problems, and even hearing loss and asthma. So these are problems that can plague this child for much longer than the peripartum time period. You were talking about, you with 2 PhDs and all the protective factors. We saw Serena Williams, the world's greatest tennis player, male or female.
Did you? I'd argue she's the greatest athlete of all time. Come on now.
Right. And she had remarkable peripartum problems that almost resulted in her death. And I think that was a big wake-up call to many of us, that if somebody like Serena can't get the health care that she needs, who can get that health care? And I think maybe we can just talk a bit about these major birth-related complications that women may suffer.
Yeah, if you could go back to that slide that you had up where we're looking at the long-term effects of low birth weight, we see these effects not just of low birth weight, but also preterm birth. I did a study that showed that in first grade, one of the greatest predictors of how well your child is succeeding by the time they get to first grade is not how great their teacher is. It's not about how great the school district is. It's not about any of those things. What's the greatest predictor by first grade is your child's birth weight. So I mentioned that I have a low birth weight baby. She was born at 4 pounds, 0 ounces, and she was 36 weeks and 6 days. So we were 1 day shy of being early term. But her birth weight is going to be and has been a major predictor of learning disabilities, physical disabilities and things like that. It can really follow a person throughout their life. Other things that we saw, as you mentioned, was asthma is something that is a low birth weight is a major predictor of having asthma later on in life. It's also a major predictor of having heart failure later on in life. So there are major sequelae that happen as a result of low birth weight. And one of the things that we tend to talk about the most is how it relates to death. But I like to remind people that death is only one outcome that we need to be concerned about. The others are, what are these long-term impacts that these babies will have to face the rest of their lives?
And then we have this, one of our previous guests, Dr. Srini Iyengar, talked about retinopathy of prematurity is associated with very low birth weight. We did discuss on the show earlier. There are many complications that can happen during childbirth, and we had a slide up there of the major morbidity. So this is not mortality, but this is something that can happen that really can negatively affect quality of life and quantity of life, frankly, for women during childbirth. So perhaps, Teresa, you can talk to this a little bit?
Yeah, and I want to also relate it back to COVID, because one of the things that we think about when we think about COVID is, we measure the number of people who died, but that is only one negative outcome. We need to also think about all the other negative impacts that happens as a result of someone having COVID. We need to think about those long haulers, and we need to think about the impact that it has on lung damage and heart complications. And so I want us to get away from thinking always that death is the only negative thing that can happen. Having major health complications that change the trajectory of your life is also one of the things that we really need to be concerned about. And as we're talking about for pregnancy, we tend to talk about that in terms of maternal morbidity or severe maternal morbidity. And those are those things that are unexpected that have happened as a result of pregnancy that will then change that woman's trajectory for the rest of her life. And once again, I'll use myself as an example. With my third pregnancy, I suffered spinal damage. And for about 9 months, I had to walk with a cane. First I had to relearn how to walk, and then had to walk with a cane for about the first 9 months. Because once again, Black women, no matter our education, no matter our status, are still negatively impacted by pregnancy and birth, and live with those complications for much of their lives.
Lauren, can we pull you back into our conversation here and talk about some of the other issues that women can face and bring them back into the ER? There's preeclampsia, and then they can still have ongoing issues after the pregnancy. Obviously, on that slide that talked about the complications of pregnancy, the blood clots weren't there. What Serena ended up having a blood clot and having something called a pulmonary embolism. But let's talk about preeclampsia and post-eclampsia.
Sure. So preeclampsia is something that some women get diagnosed in the second or third trimester. It's most classically defined in terms of blood pressure, having hypertension, and also having protein spilling into your urine. And if you're diagnosed while you're pregnant, and because your OB/GYN will be looking closely for it, they're probably more aware that, this is something that can continue up to about 6 to 8 weeks postpartum. However, for some women, they maybe were borderline, they have the baby, and then it's in that 6-week postpartum period that things start to escalate and get worse. And for some women, their first, postpartum check isn't for, 6 weeks or so, depending on what their, peripartum, course was. So it's something that can be a bit of a surprise, and in some ways it's potentially life-threatening. Preeclampsia can turn into issues with your blood cells degrading, with your platelets dropping, having kidney and liver dysfunction. And in very severe complications, you can go to eclampsia, which is seizures, which can be life-threatening. And obviously the worst outcome is death, but as Dr. Chappell was saying, sometimes people survive it, but they end up on dialysis, for example, because of the severe kidney damage from it. So it's, or if they have more of the platelet and bleeding disorder part of it, they might end up having an emergent hysterectomy, or, requiring lots of transfusions and the risks and involvement with that. So it's a life-threatening thing. And so from an emergency department perspective, we do see a lot of patients come in because some of them may have, the swelling, most pregnant women have swelling in their feet and their legs during the pregnancy, and that's not normal, but they start noticing swelling in their hands or their face, or the swelling seems to get worse. Or they're having weird abdominal pains or bruising or something unusual, or bad headaches, blurry vision, things like that. So they come in, and that's usually at the top of the list as we start sending off lab tests to look for preeclampsia. We're looking at their blood pressure. But like you said, other things that can also be causing this would be blood clots. So sometimes that's another thing that we're looking for. So unfortunately, some people feel like once I've had the baby, everything's fine. It's really, there's still this, and a lot of times we talk about for the newborns that there's sort of this fourth trimester in terms of how the newborns behave and what their needs are. I think to some degree there's a fourth trimester for women as well, where there's still some risks related to the pregnancy that extend beyond you actually delivering the baby. So it's something to keep in mind.
Yeah, and that's this is not going to be a show on postpartum depression at all, but that's another issue.
Yes.
You have the baby, everything's supposed to be fine, and you feel like everything's not fine. Everything, I mean, that didn't happen to me, thankfully, but I think, we were all right. We all have kids. So, you start thinking of all the things that could happen. Like I couldn't hold the baby and have a pair of scissors in my hand. I was convinced somehow that the baby would stick their finger into the scissor when I was using it. And I was, sometimes you have to cut a package or you're making something, you cut the, I was like, and I realized, I'm like, you're getting a little insane. I was like this, cutting.
And sometimes I hear this so much from women where they're embarrassed to come in because they think they're just being crazy, Oh, I'm sure I'm just overreacting. I'm sure it's just crazy. And sometimes it really is a sign of something more involved. And it may not necessarily, need to come to the emergency department per se, but, call your doctor, call your midwife, whoever was involved in your care, because there might be some real significant postpartum anxiety, depression, or other medical issues like the blood clots or things like that need to be addressed. So, but I think in our society, the way it's sort of built is everything's perfect, everything's wonderful, this is what you're naturally supposed to do. Once you have the baby, everything's supposed to be great. And sometimes, unfortunately, it's not great. Not to mention the fact that just also having a newborn is actually really incredibly hard. So, it's one of those things where I think our society has sort of done a disservice to a lot of women in that regard. And so I just would stress that, if you are concerned something doesn't feel right to you, get it checked out.
To finish out our club sandwich of COVID discussion, right? We have about 15 minutes left, and we want to touch base on the opioid crisis in general, but also how this pandemic has actually made it worse. There's some recent articles that came out talking about that. Everyone's focused on COVID, and meanwhile, we're having a rise in deaths with opioids.
Yeah, no, it's, I think actually just mental health and substance use disorders, it's almost an additional exacerbation of a pandemic that COVID has sort of exacerbated this already ongoing pandemic about substance use disorders and mental health disorders in this country. And I'll tell you firsthand, I'm in the New York area, so we had our first wave back in March and April, and once that kind of started to subside a bit, I'll tell you towards the second half of May into June, the next wave of patients I was seeing were all related to substance use disorders and mental health crisis. And primarily it's because of, financial instability from the shutdowns, from the lack of, federal help, to the fact that if they were already identified as having a substance use disorder or a mental health diagnosis, their normal outpatient therapies, plans, prescriptions were getting harder for them to get to, and they sort of decompensated and went to crisis or started using again. So we went through a period in sort of the late spring, early summer of not running out of beds to care for these patients, inpatient, a lot of depression, anxiety, a lot of suicide attempts, things like that. But, and this is all preceding COVID in the sense where we were having this massive opioid crisis before COVID. And as you can see from the slide here, talking about, there's increased ER visits for opioid overdose, even among elderly patients. And some of this extends back, going back 10, 15 years or so, where there was a push to better treat pain. And it's true that pain, especially for people of color, is not treated well. But what ended up happening was, and I think this is related to a lot of the lawsuits against Purdue Pharma and the Sacklers, is that it was sort of, a lot of these opioid medications were coming out and billed as being safe. You can't get addicted if you use it correctly. And we know that that's not true. And I think it's also a little bit of a testament of our healthcare system in general, where the areas hardest hit by this crisis were often in these more kind of working class, blue collar area where people have very physically demanding jobs and we're very prone to getting backaches, early arthritis, things like that. And then they don't have either the insurance access or the time or the money to do things like the physical therapy or some of the other things that we know helps with those kind of chronic pain issues. And they were given opioids and they got addicted.
Lauren, can you just, I thought it's the number 1 in 6 people that get opioids get addicted. And I think that number came out of post-surgical patients, right? Like, That you have a prescription.
Yeah, so prescriptions, and there's actually some studies that have been published in recent years looking actually at the number of days worth of pills someone is discharged with, whether it's from a surgical visit or an ER visit, that if someone is given more than like a 7-day supply, their risk of becoming addicted in the next 1 to 3 years increases greatly. So a lot of states, or a lot of, if you take your opioid prescribing, continuing education, certification things, they'll talk about that for an acute pain crisis, really to keep, if someone actually really does need an opioid to manage their pain, to only give a 7-day supply. Because once you start going beyond that, once you go, especially things like refills, like a 1 month or 3 month refill, like exponentially increases their risk of addiction. And so that it's something to be mindful of, in terms of, and if somebody really has a chronic pain issue, they really need to be in pain management. And also, just as a reminder, this is excluding people with cancer pain, metastatic cancer pain, sort of hospice palliative care kind of pains. So this is sort of more of I just had surgery, I just broke a bone, I have low back pain, things like that, of that nature, where they're at higher risk of having an issue from it. And similar with benzodiazepines, sometimes people are prescribed a short course, and the more they're on it, the more likely they can get addicted. And so again, that kind of speaks to, if somebody's struggling with anxiety issues or things like that, the ideal treatment would be actually more of therapy and potentially some other types of psychiatric medications. But sometimes the quick fix is, I'm just going to write you some Xanax. But if they're still having this ongoing stressor in their life, it's very hard for them to stop taking it, and then they become addicted to it.
Right, and I think one of the graphics we showed was the combination of drugs and self-medication, even with alcohol. Teresa, as an epidemiologist, I think you study large populations. Like, we see the patients one by one, but you really study the populations to see maybe where can we intervene earlier so that this does not become a crisis. Can you talk to your experience with that?
Sure. Yes. That's definitely one of the things we're looking at, is trying to figure out what are the risk factors and what are those things that we can do to intervene. And what we've seen a lot with opioids is that we've seen a lot of the negative impacts on both the baby and the mom. So an impact we could see on an infant is neonatal abstinence syndrome. So a baby born addicted to opioids and then having to go through withdrawal. The rates of that have gone exponentially through the roof in the last about 2 decades. We've seen that just increasingly climb. Another thing that we've seen are that women are dying as a result of opioids within that first year of life. And those overdoses that are happening are also considered a part of that maternal mortality number that we see increase across the country. So there's definitely a major kind of crossover between opioids and the maternal and child health population. And so we're looking at what are ways to intervene? How can we do things better? And so I would like to echo a lot of the things that Lauren mentioned, that there's opportunity to change the way that we're doing treatment protocols, to change the way that we're dealing with pain. And I think those things will really help those populations that are being impacted by opioid use.
You know what? I want to. We're gonna switch gears for our last few minutes. One thing we wanted to talk about was how, as moms, we're doing at home. But first, I have a question for you guys. You saw that Wall Street Journal editorial about Dr. Biden, right? And the reason I thought of this is I also do a radio show on Dr. Radio, and that Tuesday after that came out, I had female doctors on. And normally we do what we're doing here. We're like Teresa, Lauren, right? But that day we were like, I was saying Marina, because that's fine. I want to be like Madonna, Iman, and then there's Marina. So it's fine. But I was calling my guest doctor, right? And I can't even believe that the Wall Street Journal published that whole article. And for those of you guys who don't know, it was just basically some older guy that thought Dr. Biden should not call herself doctor because she's not an MD. And it was the most outrageous bit of frippery that I've ever seen published. It angered me to read it. I'm lucky I didn't blow a Barry aneurysm, which I don't think I have, but I could. I don't know. I got so angry. But, just amazing that and Wall Street Journal is also like really quiet, right? What's that media thing? Like, they're like, if you don't discuss it, maybe it'll go away. There'll be something else that comes up in the news. But anyway, wanted to hear all your thoughts. And Sujana had no idea that I was going to bring this up because it just occurred to me while I was sitting here listening to Teresa call Lauren, and I've been calling everybody by their first names. Suja, you want to start? I know you're like, I can't imagine that didn't make it to our show today.
I know. I was already so angry. I think I left it out. Not only was the op-ed disgusting, but in fact, the journal editor's response was even worse. And it was so disrespectful to women, to doctorates in education, to non-MD. I'm pretty sure Dr. Jill Biden is not going to whip out a scalpel and take out anybody's appendix when she's in the White House. I'm pretty certain she won't do that. So I found it disgusting, and I think you're right. I mean, there's a lot of data. When women introduce other women and men at, let's say, medical meetings, about 97% of the time, even if they're our best friend, I'll say, and our next speaker will be Dr. Kurian. Whereas when men introduce men, they use doctor about 70% of the time. And when they introduce women, it's actually less than 50% of the time. And that happens whether you're giving an invited lecture, whether you're the doctor coming in for a consultation, whatever you are. We are not awarded or afforded the honorific that we have worked so hard for. So, yeah, I was furious, as I think were most of us. And I think it leads into mothering during COVID, mothering as a professional during COVID. And maybe, my first baby was born 25 years ago today. So my mothering is a little different than yours. But Teresa and Lauren, or Dr. Chappell and Dr. Sean, you have smaller children. How has that been for you? And maybe we'll start with Lauren.
Yeah, this is, it's been an issue on a personal level, but also just on a societal level. People have been talking about this, female recession, she session, or however they're calling it, of women having to leave the workforce really due to COVID issues with school and childcare. And I would say, again, this is an example of COVID not necessarily causing this. It is just ripping off the surface of an already tenuous condition that was existing in the United States in terms of women being in the workforce, balancing home responsibilities and work responsibilities, and sort of the inequities of family leave, childcare, things like that in the United States. So it's a symptom of a bigger issue. So I think especially when this is come up is with the schools, that a lot of schools were not able to open in person or doing hybrid models, and the difficulty of making sure, especially when you have a young child, like my oldest child is 7 in second grade, like he cannot do remote learning by himself. Like he needs help and somebody has to be there. I think that came up for a lot of families. And I think in most of the situations, it was the female parent being involved in that, having to make that decision about, do I work? Do I stay home and help? Can I do both? And it has less in that sort of traditional heterosexual nuclear family. That's been sort of more of the dynamic. And obviously there's also single parents who are even struggling way harder than that. So, it comes back to this idea as a society, if we value having a diverse workforce, if we value having women being involved in our work and our policies and things like that, then what do we do to promote them being there in terms of our child care policies in the United States, in terms of our healthcare policies in the United States, and then also in terms of the fact that we're also seeing a huge inequities for both people of color, people of lower socioeconomic status. They don't even have access to proper remote schooling if their school needs to be shut down. And there's going to be this is going to potentially affect an entire generation of people.
I think
exactly.
Teresa?
I just want to jump in. I think we only have about a minute left, but I make my children call me Dr. Mommy. So
I love it. Perfect. I want to thank you both so much. Our guests, Dr. Teresa Chappell and Dr. Lauren Shawn. We could talk to you for hours. Thank you so much for sharing your wisdom and your knowledge and your experience with epidemiology, emergency room, maternal child health, opioids. We found this graphic that greatly reflects 2020 with masks going into 2021 with just a mask and a syringe of vaccine, we hope. We want to thank so much our production team. We are very grateful to all of them. Without them, we could not make this show happen. We are really grateful to our viewers. We've had over 75,000 views since we started in June, and we've had 53 guests, including our two incredible guests today. So thank you so much for watching us. And Marina, we're off next week.
Yeah, we'll take a day off, and then we come back in the new year with hopefully some great tidbits on habits and workout tips, because that's how we're all going to start off the new year. Thank you so much for watching, you guys.
Thank you. Happy holidays, everybody.